Now, in this entire module, you will find that a little bit of there could be overlapping of various topics, which is very important because anesthesia would not work without understanding how it acts. So it's very important that we know how different things happen. Welcome back to lecture 3. This is the structure of the neuron and the conduction cascade. So it's very important to understand the structure of the neuron because that is the fundamental basis of the impulse conduction and how we react to a particular thing. So this is a artist's depiction of the neuron, and in real sense it is slightly different, which we'll come to know in the subsequent classes. So what are the basic classification of the peripheral nerves? What we are concerned is with the alpha, delta and the C fibers. These are the ones that lead to the various conduction, that is proprioception, to the pain, temperature and touch. So the delta fibers need to be very well coated by the local anesthetic solution. Otherwise, this leads to a problem where we have inadequate anesthesia. So the pain, temperature and touch need to be blocked properly. And of course, the C fibers would have various autonomic functions such as pain, temperature and touch again. And this is how the gate control acts. The neuron or the nerve cell is the structural unit of the nervous system. It is able to transmit the messages between the central nervous system and the parts of the body. There are two types of neuron, which is the sensory, that is afferent, and the motor, which is efferent. So the first image that we are going to see is the unipolar neuron, that is the sensory neuron. Now this has three parts. Now this is a little different from the multipolar or the motor neuron, which we are going to see subsequently. So it has got a dendritic process, the axon, which is this long which looks like a cable, and you have the cell body with the nucleus. This would lead to the impulses to the CNS, including the brain and the spinal cord. This is the place where the impulse happens, that is the periphery, and then it is conducted along this particular path or the chain that we see over here, and again which is sent to the brain and the spinal cord. The motor neuron would, the brain or the spinal cord, when it interprets that, it is going to send a response through the motor neuron, and this is the structure of the motor neuron is completely different from the sensory neuron. That means it has got which is multipolar, and it carries the impulse away from it toward the motor end plate. So that is why we see basically the patient would be shrugging, blinking, or moving away from the pain. This is how we interpret it and how we react to pain. So it's very important that we understand how the sensory and the motor nucleus behave. The axon terminals synapse with the muscle cells. So these are the axon terminals which must synapse with the muscle cells or the motor neuron end plates. The nerve structure is basically, it is got, if we look at this kind of a cross section of the nerve, you have the nerve sheath which has got the Schwann cell, and you have the axon. Now the nerve sheath is like if you have an electrical wire. So the wire is the one which is insulated would have a plastic or a rubber component over it, which prevents it from getting short circuited. So this is essentially how the nerve sheath behaves, and within that nerve sheath there are small breaks which is called the nodes of Ranvier. Now this nerve sheath, if we again look in a cross section, the unmyelinated if you look at the nerve in the cross section, you got the unmyelinated nerve sheath, so it's not completely covered by a sheath and it is open at the ends. So De Jong has described the nerve impulse conduction as the one being like the one active progress of a spark along the fuse of a gunpowder, which we talked about earlier. Now once lit, the fuse burns steadily along its length, with one burning the next one necessary to ignite its neighbor. So this is the importance of knowing the structure of the nerve sheath. And within that particular, if we see it like a illustration, you have the axon, you have the depolarized membrane. which is at the nodes of Ranvier, and the membrane at its resting potential. So this is basically how the impulse is carried forward. So the nodes of Ranvier are gapped in myelin sheath along the axon. The nerve contains voltage-gated potassium and sodium channels. The action potentials travels down the axon by jumping from one node to the next. In the next image that we are going to see would basically be a very simplified diagram which you talked about earlier, but again we need to talk about it now, is basically how the nerve sheath is present. So at the resting potential, if we imagine that there is a voltmeter and it will show a resting potential of minus 70 to minus 80 millivolts with the sodium ions being outside, and you have the potassium channel where the potassium is prevented from going outside and the sodium is prevented from getting inside. But once that happens, with the help of ATP and ADP, the sodium channels, they open, the sodium gets inside, and there is efflux of the potassium ions. And later on, again the gate closes where you have the sodium ions which are present at the end, outside, and this potassium being inside. So in the depolarized state, we have a positive voltage of 40 millivolts. This, like I said earlier, would allow the sodium from getting in gradually, and that will get inside the. This is happens when the impulse is generated, and this is basically when we see the sodium getting in through the nerve membrane. In the hyperpolarized state, again it leads to a voltage of 70 millivolts, minus 70 millivolts, and the potassium ions which are outside would try to get in, and the sodium is present in the nerve membrane. In response to the signal, the soma end of the axon becomes depolarized. The depolarization spreads down the axon, and the first part of the membrane repolarizes. Because of the sodium channels are inactivated and the additional potassium channels are open, the membrane cannot depolarize again, and the action potential travels down the axon continuously. This is what we talked about a little earlier. The diagrammatic representations are slightly different to make it even more simplified. So the direction of the action potential would be the depolarization. Initially it's depolarized, then it gets repolarized, and it keeps going ahead where it gets depolarized, repolarized, and ultimately the resting potential in that particular fashion. So this is how we can explain the basic amount of polarization that happens. In lecture 4, we are going to talk about the site and mode of local anesthesia on the nerve membrane. So if we look at the next image, which is basically if we have local anesthesia, which is outside, basically local anesthesia comprises of both charged and uncharged molecules. Now what we need is the uncharged molecules which needs to get inside. The charged molecules won't get inside. The uncharged molecules would try to get inside, and this uncharged molecules will go into the sodium channel gate. This will prevent the influx of the sodium channel, and this is how we can explain the action of local anesthesia. So as such, if you look at it, the charged molecules it is impossible for them to get inside. They have to dissociate into uncharged, and this uncharged molecule, which again binds with this hydrogen ion, and the local anesthetic molecule prevent the sodium from getting inside. So the proposed mechanism of action of local anesthetic molecule is that the molecule displaces calcium ions. The RNH plus displaces the calcium ion for the sodium channel receptor site. This causes the binding of the local anesthetic molecule to the receptor site. This in turn produces the blockade of the sodium channel, and in turn it leads to the decrease in sodium conduction, which in turn leads to depression of the rate of electrical depolarization and ultimately the failure to achieve the threshold potential level. And ultimately, the lack of development of propagated action potential is called conduction blockade. This sounds complicated, but in reality, this is essentially how every time we inject local anesthesia, whichever molecule that we use is responsible for its action through this particular phase. The local anesthetic molecules interfere with the excitation process in a nerve membrane in one or more ways. That is, altering the basic resting potential, altering the threshold potential, decreasing the rate of depolarization, and it leads to the rate of repolarization. So the factors affecting the local anesthetic action, or how the local anesthesia would act in presence of different situations. That is, if it is the lower dissociation constant happens, then there is more rapid onset of action of the RN molecules which are present, which are able to diffuse through the nerve sheath. Thus, the onset time is decreased. However, if it is more acidic, then obviously it leads to an issue of the dissociation of the local anesthesia. Second is lipid soluble. Increased lipid soluble results in increased potency of the drug. That is, procaine is 1 and etidocaine is 140. So the etidocaine produces conduction blockade as very low concentration, whereas procaine poorly suppresses the nerve conduction even at high concentration. The protein binding which is there, this leads to the anesthetic cations being more firmly attached to proteins located on the receptor sites. Thus, the duration of action is increased. If there is a non-nervous tissue, then obviously the onset is decreased because of the presence of the non-nervous tissue. In cases of vasodilator activities, the anesthetic potency and duration is affected. The greater vasodilator activity increases in the increased blood flow to the region, resulting in rapid removal of the anesthetic molecules from the injection site. Thus, the anesthetic potency and duration are decreased. Now, what happens is, this can be explained very simply. If we use lignocaine without epinephrine or adrenaline, what happens is that essentially most of the local anesthetic molecules, barring cocaine, they are all vasodilators. So this allows for greater blood flow and the absorption is faster. So when the absorption is faster, we need to inject more if we are doing a long procedure. And in such cases, it is not advisable. If the patient is moderately hypertensive, then we can use lignocaine with epinephrine, that is up to 4 ml of 1:100,000 solution of adrenaline, and this leads to a greater patient comfort and therefore preempting the action of catecholamines, endogenous catecholamines, which are deleterious for the patient. Lecture 5 is classification and mechanism of action of the drug. So basically, when we look at the molecule, whether it is an ester or an amide, you have the two groups which are there. The B is the amino ester and C is the amino amide. So amino esters are not used commonly nowadays, with the exception of articaine, which is a combination of ester as well as amide. The most commonly used amide local anesthetics is lignocaine or bupivacaine, and they are very safe. They have very less hypersensitive reactions or cause adverse reactions in the patients. So the classification of the local anesthetic solution is essentially based on the chemical structure. How are they made available chemically? So you have esters, which are benzoic acid esters or esters of para-amino benzoic acid. So the benzoic acid esters comprise of butadiene, cocaine, which is the naturally occurring local anesthetic, benzocaine, hexylcaine, piperocaine, and tetracaine. The interesting story about cocaine is that the American Indians in Latin America, they used to consume cocaine, and this used to cause circumoral numbness which was there, and this led to the discovery of cocaine, which is used for topical anesthesia. It cannot be used for uh, block anesthesia because it's got an addiction potential. Sometimes the ophthalmologist may use cocaine drops for topical anesthesia for any eye surgery or minor ophthalmic procedures. The para-aminobenzoic acid esters are chlorprocaine, procaine, which was one of the benchmark anesthetics before the lignocaine came into existence, and propoxycaine. The quinolone derivatives comprise of senbutridine, which had gained a little traction in the early part of the 21st century, but however, it is not used nowadays for various reasons. It had the advantage of being a local anesthetic which had a vasoconstrictive property. The amide ones, which are the most standard ones which are used, are comprised of articaine, bupivacaine, etidocaine, lidocaine, mepivacaine, and prilocaine. Mepivacaine is essentially useful because we can use it without vasoconstrictor in patients who got some cardiac conditions or who are hypertensive. The second classification is based on the mode of application. Where do we use it? So the topical local anesthetics are the ones which are soluble and the ones which are insoluble. So cocaine, lidocaine, tetracaine, and benoxynate are the ones which are used for topical anesthesia, and the insoluble ones are benzocaine and butyl amino benzoate. We use them as a preparatory technique for local anesthesia. That is, if you want a totally painless local anesthetic procedure, let us say, for example, in young children or those patients who are very anxious, one could use a topical anesthetic at the site where we are going to inject it, and this leads to less painful injection. There are other methods of also achieving painless anesthesia, but this is one of the most commonly one used which are there. The injectable ones, the ones which we use most frequently, are lidocaine, mepivacaine, tetracaine, bupivacaine, and dibucaine, and of course articaine. Based on the duration of action, you have ultra short, short, medium, and long. That means how much of action you want. Suppose you're doing a short procedure, you want a short pulpal anesthesia, or you're just wanting to remove a suture. In such case, an ultra short acting would be used, where you can use chlorprocaine. For a short anesthesia, you can use lidocaine or prilocaine. Short to medium, it's very difficult to say how much of action is there. This is where you can use mepivacaine, which provides you good pulpal anesthesia for 45 minutes to 1.5 hours, and soft tissue, which is about roughly for about nearly 4 hours, which is there where you can use mepivacaine or articaine. The long-acting ones are bupivacaine and etidocaine. Bupivacaine has got very long onset. One can use it as a supplemental anesthesia when you've done a long procedure and you want lesser dependence on analgesics. One could always inject bupivacaine at the end of the procedure, or by the time you're finishing the procedure, you can use it, and this gives you good results as far as post-operative pain is concerned. Now, based on the site and mode of action, that is class A, which are agents which act on the receptor site or the external surface of the nerve membrane, which are called as biotoxins, that is teratotoxin and saxitoxin. Now, this is most commonly, one finds it not of great use in our clinical practice. This is present in a fish called puffer fish, which is very extremely toxic and poisonous to eat, and you need special preparation for that actually. Type B is agents acting on receptor site on the internal surface of the nerve membrane. These are quaternary analogs of lidocaine and scorpion venom. We don't use scorpion venom anecdotally. Type C is agents acting by receptor independent physiochemical mechanism, that is benzocaine. And type D is acting by a combination of receptor and receptor independent mechanism. The most commonly useful anesthetic agents are articaine, bupivacaine, lidocaine, mepivacaine, and prilocaine. We'll talk about the various drugs as we come to it. So, calculation, I've talked about this earlier. Now imagine a situation where there's a healthy female patient of 22 years weighing about 50 kilograms. So if you want to use the routine local anesthetic, one can use epinephrine of 1 is to 100,000, and the amount would be if you calculate a cartridge which has got 36 milligrams per cartridge. So lidocaine with adrenaline becomes 350 milligrams. So you just need to multiply the weight of the patient by 7 milligram, you get the maximum dose. If you are talking about a patient who is 100 kilograms, does not mean that you should multiply 7 again by 100, which will lead to toxicity of the local anesthetic. If there's a patient of 40 years old, who's 40 years old, and a male patient who's 90 milligrams, again, it becomes 630, but not, this is for Articaine, so it becomes 630. Now, why does it become 630? Is because Articaine is present in a concentration of 4%. If there's a patient of 6 years, a healthy male child of 6 years, weighing 20 kilograms, the favored local anesthetic would be mepivacaine, or one could use lignocaine in Indian situations. So again, you need to multiply that. However, one needs to keep in mind that you have to be absolutely sure about aspiration. Now, what happens is that even with a small dose, it can lead to a lot of toxicity, because the facial vessels, the veins are valveless veins, and it can lead to direct absorption into the brain and cause toxicity even with a small amount of drug. The theories of mechanism of local anesthesia would be, we talk about a lot of theories, but what are the ones which are most commonly proposed and the one which are most commonly would be talked about. So you have the calcium displacement theory, the surface charge theory, the membrane expansion theory, and the specific receptor theory. The first three theories are not very commonly accepted. The latter two are the ones which are usually considered, and we'll talk about them. So the membrane expansion theory is basically, when we talk about it, it states that the local anesthetic molecules diffuse to the hydrophobic regions of the excitable membrane, producing a general disturbance of the bulk membrane structure, expanding, which will prevent the sodium influx and preventing an increase in the permeability of the sodium ions. Membrane expansion is one of the most accepted theories. However, there are certain agents which would act in a different way, and that is how the specific receptor theory comes into play. The tertiary amide local anesthetics inhibit the influx of sodium during the conduction by binding to a receptor within the sodium channel, and this blocks the normal activation mechanism of the gate. The gate configuration also promotes the movement of the activation and inactivation gates, leading to a position that resembles the stage of an inactive gate. So this is basically how this particular illustration shows you how the sodium channel is prevented from the sodium getting inside by the local anesthetic, which acts on specific receptors such as lidocaine, prilocaine, mepivacaine, articaine, and bupivacaine. Again, like I said, the sea anemone venom and the scorpion venom, which we don't use, but however one could get affected by it, also works in this particular way only. The local anesthetic agents, when we come to it, comprises of the amide group, which is the most common one. It is more vasodilating than mepivacaine. The pH of the plain solution is 6.5. However, when we add a vasoconstrictor, it becomes 5 to 5.5. That means it's pretty acidic. The onset of action is 2 to 3 minutes, which is pretty good. It is rapid. And the effective dental concentration that we use is 2%. The anesthetic half-life is 90 minutes. So therefore, we can do a minor oral surgical procedure, fracture reduction, which does not require a lot of manipulation, or a third molar surgery within this particular period. You can also put many implants in this particular way if we tend to work very efficiently and rapidly. The articaine is a combination of esters and amide. It's got a The pH of the plain solution is 5.7, and with the vasoconstrictor is 4. The onset of action is 1 to 6 minutes, which is again a decent onset of action, and the half-life is 20 minutes. So the Articaine which is used can be used in where you need not give a block even for the mandible, because it tends to diffuse through the bone very effectively due to the presence of the thiophene ring. Now, the maxillary permanent tooth removal without the palatal injection is possible in this particular article, because, like I said earlier, the diffusion through the bone is very good. So it reaches the palatal root also, as well as the palatal mucosa, and by this way we can carry out extractions where you don't need to give a palatal injection. The palatal injection is one of the most painful injections, even if you use a topical anesthetic or the techniques where you kind of distract the patient or doing whatever. It is very painful. Articaine overcomes all that and gives you a good anesthesia for the maxillary removal of the maxillary molar. So it has got a very unique systemic safety profile. That is, it circulates into the blood, it is degraded into the liver, while lidocaine, it takes 90 minutes for degradation, and mepivacaine is 110 minutes of degradation. Articaine is degraded by the enzymes in the blood flow and 5% in the liver, and articaine is absorbed very fast, that is 30 minutes. So therefore there is no residual drug which is available in the blood. The articaine benefit it's pretty beneficial as compared to lidocaine. That is, it's got a faster onset of action. It is more liposoluble. That means it's got a higher potency because it tends to bind with the molecules on the nerve membrane. The protein binding would ensure that it has got a longer duration, and the degradation mode, which we just talked about, says that it's got a better safety profile, and this is essentially how it acts. The third one, which is a representative one that we are going to talk about, is bupivacaine. It's an amide local anesthetic, essentially used more in spinal anesthesia than in our surgeries. However, this is not to say that we can't use it. If you've done a procedure that is pretty intense and which lasts a long time, we have removed a deep-seated impaction. In such cases, providing supplemental anesthesia through bupivacaine is very good. The anesthetic half-life is 2.7 hours. That means the patient is comfortable for nearly 5 to 6 hours after injection. I'm not endorsing any particular brand here. So there are different brands which are available, and one could use it in a variety of ways to give supplemental pain relief for the patient. The anti-inflammatory action, however, is not going to be provided by this. So one needs to be very sure of that. Only the pain is controlled, and therefore reducing the dependence on greater number of analgesic activities. Now, what is EMLA? EMLA is the eutectic mixture of local anesthetic solution. It's a cream which is available, which is composed of 2.5% lidocaine and 2.5% prilocaine. It's it's an oil base, and it is available in a 1:1 ratio by weight. It is basically used for cutaneous infiltration. Before you do the cutaneous infiltration, if one does EMLA application, the patient is more comfortable. The pharmacokinetics of the local anesthetic, the uproute is by the topical way or the injectable fashion. The metabolism esters is by the pseudocholinesterase, and by amides is to the hepatic microenzyme, and obviously all of them undergo excretion through the kidney. The maximum recommended dose of local anesthetics is articaine is 7 milligrams per kg body weight with a vasoconstrictor, and without vasoconstrictor is 3.2. Lidocaine is 7, and again 3.2. The molecule of lidocaine and articaine are essentially, they've got similar behavior. So more so, it has got the similar amount of maximum drug dosage which is available in both the cases. The serum lidocaine concentration and systemic effects is that one needs to be very sure about what is one injecting and how much one is injecting. So one needs to be very sure, and like the case presentation that we had about the female patient, the male patient, one needs to be very sure about how much one is injecting. So if you inject more, there could be toxicity, and further it could lead to respiratory and cardiac arrest. The patient could go into seizures, and it could lead to a lot of problems for the patient. So one should always count the amount of local anesthetic that one is injecting. The best way to do so is to use a cartridge where we are sure that either it's going to be a 1.8 ml solution or a 2.2 ml solution. So we know how many cartridges we have used, and in that way how much we have injected. Because there's a chance that the assistant could load a 5 cc syringe once and then a 3 cc syringe, and this could lead to a lot of problems. We are unsure about how much we've injected. Now, this leads to a situation where can we reverse the effect of local anesthetics? And this can happen with the use of phentolamine mesylate, which is a vasodilating drug. Now, this is basically, it is used in younger age group where the patient is not very well versed with the effects of local anesthesia and could result in a lip bite. This particular lecture, it's beyond the domain of discussion. My colleagues would be discussing how we can overcome the toxicity and what is the reversal of local anesthesia. So the next lecture, the penultimate lecture, is on the dissociation of local anesthesia. So the impulse needs to be stopped. So we talk about how the local anesthetic molecule is dissociated into Rn and H+. The local anesthetics are available as acid salt, usually hydrochloride, for clinical use. The acid salt of the local anesthetic, both water soluble and stable, is dissolved in sterile water or saline. In this solution, it exists simultaneously as uncharged molecule, that is Rn, and also as the base, which is positively charged molecules, that is RNH+. Now, the positively charged molecules are the ones which diffuse into the nerve membrane. As the pH of the solution is acidic, the hydrogen ions are also present. The relative proportion of each ionic form in the solution varies with the pH of the solution and the surrounding tissues. In the presence of high concentration of hydrogen ions or low pH, the equilibrium shifts to the left, and most of the local anesthetic solution exists in the cationic form. So therefore, it will be Rn plus H+. The relative proportion of the ionic forms also depends on the pKa, or the dissociation constant of the specific local anesthetic. The dissociation constant is a measure of the affinity of the molecule for the hydrogen ions. When the pH of the solution has the same value as the dissociation constant of the local anesthetic, exactly 50% of the drug exists in the RNH form and 50% in the Rn form. The percentage of the drug existing in either form can be determined from the Henderson-Hasselbalch equation. Now what we are going to see next is an image of how this happens. So if we imagine that is 1000 number of local anesthetic molecules, 750 exist as RNH plus and 250 as Rn. And when it dissociates, you got the Rn form. It again leads to the formation of 70, and this leads to the effect of the local anesthetic which takes place. The effect of decreased tissue pH, that means if there is acidic tissue pH, what happens is that there is decreased absorption because the amount of dissociation that happens is much less. So one needs to overcome that. Obviously, you're not going to inject in a site which has got pus or abscess tissue. So one needs to control the infection and then inject. One needs to take care that there is no inflammation at that particular site, which could lead to lesser amount of the anesthetic molecule getting inside the nerve membrane. The dissociation constant of various agents is like for lidocaine, it is 7.7, and the approximate onset of action is about 2 to 4 minutes, like we discussed earlier. Articaine is essentially the same. They share the same profile. However, Articaine is a little safer to use as far as the pediatric age group is concerned, as well as for the patients who need maxillary extractions. What are the clinical implications? The local anesthetic solutions are essentially with a low pH, and they get further acidified with the addition of the local anesthetic solution. The tissues adjust a lot to manage the acidified local anesthetic solution by enormous buffering. The slower onset of action is basically because of this as compared to those without the vasoconstrictor. Now, if we look at the composition of the nerve fiber, this is very important to understand the structure of the nerve fiber, because the anesthetic molecule needs to diffuse into every part of the nerve. So it's very vital that we understand what is the perineurium and what is the endoneurium. So the perineurium is around one fascicle, and you have the endoneurium, which is one particular nerve cell. And lastly, you have the epineurium, which covers the peripheral nerve. We'll just describe it in this particular image, where you have the core and the mantle fibers. The anesthesia needs to diffuse right into the core fibers. So if you are not in close proximity with the nerve cell, or if you are using improper concentration of the local anesthetic molecule, then obviously the core fibers would not get affected. What is the clinical implication here is that we inject. However, the patient would say that the patient has got anesthesia on the lip. However, when you try to extract the tooth or luxate the tooth, the patient has got intense pain, because those which supply the pulpal anesthesia and the periodontal anesthesia would be from the core fibers and not the mantle fibers. Mantle fibers would be essentially more superficial, and that will only give the implication that the nerve entirely has got anesthetized. So one needs to objectively and subjectively measure the anesthesia and ensure that you use the proper technique of depositing the local anesthetic solution in the vicinity of the nerve. This would be taught by my colleagues in the later lectures, so that we get the proper and optimal anesthesia without causing any untoward symptom or effect to the patient. Now, after deposition of the local anesthetic as close as to the nerve possible, the solution diffuses three-dimensionally. It will, obviously, since it's a blind technique and we don't know we can't know the presence of the nerve through the tissues, the drug is absorbed by the non-neural tissue, that is muscle and fat. Some is diluted by the interstitial fluid. Some is removed by the capillary and lymphatics, and the ester types are hydrolyzed by the plasma cholinesterases. The sum total effect of these factors is to decrease the availability of the local anesthetic concentration outside the nerve. However, the concentration of the local anesthetic within the nerve continues to rise as the diffusion progresses. These processes continue until an equilibrium results between the intraneural and extraneural concentrations of the local anesthetic solutions. Now we come to the last part, that is the properties of vasoconstrictors and their role. Vasoconstrictors obviously have a very vital role in the local anesthetic solution. We have discussed it very often, and I'll just reiterate what we have learned so far. Vasoconstrictors could be either epinephrine, these are acetylcholines, and you got epinephrine, levonorepinephrine, and non-epinephrine based on the structure on the benzyl ring. These constrict the blood vessels and therefore control the tissue perfusions. They are added to the local anesthetic solutions and to oppose the inherent vasodilatory actions of the local anesthetics. They are, by nature, they are vasoactive. That is why they are called vasoconstrictors, and they would constrict the blood vessel, because we need to use them, because most of the local anesthetics are vasodilators, barring cocaine, and cocaine we don't use in our practice. So mepivacaine is a relatively cardioprotective local anesthetic, but we don't usually get it in India. This causes an issue of hemostasis. So obviously, when you want a bloodless surgery, you can use local anesthesia with adrenaline. The higher amount of anesthesia is needed if you don't use it. And obviously, if you don't use it, it results in discomfort and reduced duration of anesthesia. You cannot keep on injecting local anesthetics, where we come to the factor that we have known how much of lignocaine can be injected in a particular patient, lignocaine or articaine, because we've talked about the concentration and how much can be used in a particular patient. This counteracts the vasodilation, it reduces the blood flow, it reduces the need of the anesthetic, therefore reducing the the incidence of toxicity or the cascading of toxicity, and duration of action is increased. Vasoconstrictors on their own can be used to manage acute allergic drug reactions, decreases bleeding, aiding in hemostasis. Not only it is used as a local anesthetic, we can also use the local anesthetic when we are incising on soft tissues, where it is going to give you a bloodless field and what is known as hydrodissection, and this causes the reduced risk of toxicity. How do we select the vasoconstrictor? The duration of the desired effect, physical condition of the patient, desire to achieve hemostasis, and concurrent medication. We don't use noradrenaline as a vasoconstrictor. So essentially, in India, we use local anesthesia that would contain epinephrine. Now, the duration of the desired effect. So if we need a longer duration, we can use adrenaline in a greater concentration, but taking care of the fact that the patient's need for the hypertension has to be taken into account. The physical condition of the patient, age is one factor. Greater the age of the patient, one needs to be cautious while using the local anesthetic with the vasoconstrictor, and the desire to achieve hemostasis and concurrent medications. So one needs to factor all these things while using vasoconstrictors. They are an extremely beneficial group of agents which are available for the use. How do you use the dosage and titration? 100,000 epinephrine means 1 gram of epinephrine in 100,000 ml of solution. 1000 milligram of epinephrine means in 100,000 ml of solution. Hence, only 0.01 milligram of epinephrine is available in 1 ml of solution. And the maximum recommended dose for individuals is 0.2 milligrams of epinephrine per appointment. So one needs to be very cautious about the local anesthetic which you're giving. Usually what could happen is that in clinical practice, we get a local anesthesia of one particular manufacturer, and ultimately we find after a few months that that particular brand is not available, or the manufacturer is no longer manufacturing it, and we get some other brand. So one, make sure that what is the concentration of vasoconstrictor available in that particular use. Now, the medical conditions that limit the use of vasoconstrictors is that if there is a congenital heart disease, the vasoconstrictor needs to be minimum or omitted. You can choose to use this in consultation with the patient's physician or the cardiologist. In rheumatic heart disease, minimal vasoconstrictor. In coronary heart disease, omit the vasoconstrictor. Again, one could always consult the cardiologist. The congestive heart failure, minimal or omitted. And in diabetes mellitus, it is minimal or omitted. The recommended dose for vasoconstrictors, that is maximum in epinephrine in a normal ASA1. Now ASA1 means American Society of Anesthesiologists, who have graded the patients from 1 through 5. So ASA1 is a normal healthy individual. Is if you are using a 1:50,000 concentration, it becomes 5.5 cartridges. 1:100,000 would become 11, and 1:200,000 would become 22 cartridges. If there's a cardiovascular patient, then with ASA 3 or 4, then obviously it drastically comes down, as we can see from the table. I would like to thank you for your patient audience, and I would also like to thank NPTEL and the team which has promoted this. And I would also like to thank my residents who have helped me with my presentation. Thank you so much, and wish you all the best in your clinical practice as well as your academics.